it's 7 o'clock, so we should get started because Greg probably has procedures to do starting at 8. So Greg Davis, for those younger people who may not know him, is clearly one of the leading sinus surgeons in the country, certainly in our region, and a longstanding colleague. Going to talk today about probably one of the most common fundamental things that patients come to us looking for treatment. Nasal congestion assessment and treatment couldn't be a more pragmatic and important talk for us to have. So Greg, thanks very much.
Appreciate it, Len. Thanks for the invitation again. I always enjoy speaking with this group and look forward to the days that we can do it in person or choose to do it in person again. Your introduction said for the younger people, which means by default, I'm getting older, and it's true. That's right. It's better than the alternative. I started my career at the University of Washington and went on to direct the Rhinology program, and then found the Rhinology Fellowship. And after 12 years in academics, decided to try something new. So about 3 years ago, I left academics for private practice. But I've stayed quite academic. I am on the board of directors for the American Rhinologic Society and still do quite a bit, actually probably more research than I did at the university, because it's so much easier to do in the private sector, at least as far as industry grants. So I think it's probably the 6th or 7th year I've spoken with this group, and I always try to come up with something new and different. And I was sitting here a few months ago trying to figure out what to talk about. And I spent a bunch of time talking about polyps and the new techniques and surgeries and things like that for polyps and smell loss and other things common in rhinology. And then I came back to nasal congestion, and it's such a common problem that we all face. And I was thinking about, trying to put myself in your shoes. Would you want to hear about nasal congestion? And we'll see how this goes. I know it's an important topic, and your patients complain about it because some of those patients make it in to see people like me to consider surgery. But there are some newer treatments that are available that are worth you knowing about, so that you can tell your patients about it as well. So with that, let's get on to my disclosures have increased in private practice because it's easier. None of these disclosures relate to the material I'm going to speak about today. I am hoping to talk about nasal congestion and that it doesn't require true surgery to improve. There's been a big shift in rhinology to get patients out of the operating room and do more and more procedures in clinic. And it's cheaper, it's much easier on the patient, and much just easier to facilitate with a much smoother recovery. And then I want to talk about nasal valve collapse, and I'll define that for you momentarily for those that aren't aware of it. So the problem is that a lot of us, myself included, have nasal obstruction, and that's 6% have true nasal obstruction where they can't breathe through their nose. There's a much, much higher percentage of patients complaining of nasal congestion. And the symptoms of obstruction obviously relate to congestion, but it dramatically complicates sleep, snoring, headaches, fatigue, poor exercise tolerance. And now one of the more common reasons I see referrals are from the sleep disordered dentist. Those dentists who see patients and do mandibular advancement devices, they're very, very concerned that the nose is one of the problems that leads to TMJ disorder. And if we don't fix the nose, then people have poor sleep tolerance. They are mouth breathers at night, which increases the chance of dental decay. And so kind of shockingly, I see more and more patients coming from dentists than other providers, which I find interesting. There's lots of causes for nasal obstruction, a deviated septum, and I'll tell everybody, everyone on the planet has a deviated septum to some degree. There's always a little twist and turn or a bone spur. It's just how severe that is what bothers patients. Inferior turbinate hypertrophy, obviously common in allergic rhinitis and other types of rhinitis. The septal swell body, I'll show you an example of that. Sinus disease, nasal polyps, allergic rhinitis, and then again, nasal valve collapse. So when you see a patient and they come in complaining of allergies and, oh yeah, I can't breathe through my nose, the three things that I think are important to ask about in addition to the allergy questions are, do they have a history of nasal trauma? And I generally say, did you run into a basketball or an elbow playing a sport? I try not to ask people if they got in a fight, even if the patient seems like someone who might have gotten in a fight. That tends to set a negative tone. It's really important to ask if they've had prior sinus surgery, mainly from a surgical standpoint of knowing how complex it's going to be. It's always easier to do the right surgery the first time, and it's a little bit more challenging to do revision nose surgery. Doesn't apply to revision sinus surgery. That's always the same and not any more challenging, really. And then nasal medications, are they abusing their decongestants? And I am showing this next section a little bit out of order because I couldn't find a better place to put it. So when patients come in with rhinitis medicamentosa and they've been on their Afrin spray, 2 sprays to both sides once or twice a day for years, what do you guys do? I'll show you what I do. First things I do is put them on a nasal steroid spray twice a day, usually for a week leading up to Afrin serial dilutions. And I made this, yes, I made it. So I'm not a graphic designer, but I made this little serial dilution image that I print out with instructions and I give it to patients. And essentially they take their bottle of Afrin, a full bottle, they pour half out and they fill it back up with saline. And they do that every 3 days. They're diluting it by half. And so by the 8th day, they're hardly, or by the 8th dilution, so 24 days later, they're hardly using any Afrin. And it's a kind of akin to the Nicoderm patch. It's just a nice way to wean off of it if they don't want to go cold turkey. Most patients can tolerate this, some can't. And if they can't, then there are some surgical procedures that will get them over their Afrin addiction. I have seen massive nasal septal perforations, and I even saw a large palate perforation without cocaine exposure, allegedly, that was attributed to Afrin abuse. And then ask if they've used breathe right strips or nasal cones. And the reason this is an important question is if they have and it helps them, then it tells you that it's the nasal valve that's the problem. And the nasal valve is the side wall of the nose and the septum, and then the head of the inferior turbinate. I'm going to show you an image of this in a moment. But think about it, nasal breathe right strips and nasal cones, they don't at all change the trajectory of the nasal septum. They don't decrease the size of the inferior turbinate. So if these do help, then you know it's the nasal valve, and that can help point you to steering that patient into a different direction. When my friend Brent Sr. took a look at over 90.
Can I ask you a question? Those nasal cones.
Always ask a question. Yeah.
That nasal cone that you showed a picture of,
Yes.
is it, you have to prescribe that, or can people buy it just like they buy breathe right strips?
Yeah, it's like $10 on Amazon. And again, this comes from the sleep dentists. Most patients who come from a sleep dentist have tried these nasal cones. I think the dentist sells it to them with a little markup, but not many patients tolerate them long term. It's they're irritating. You can just imagine they're kind of irritating to keep in the nose, and when used for several weeks in a row, it starts to cause a little abrasion inside, and some people get sores or even some bleeding. So my preference is, if people haven't tried a breathe right strip, I send them home with a breathe right strip, or I tell them to go buy a breathe right strip. Yeah, they're over the counter. When looking at 1,900 patients, the question was, in these patients with nasal congestion, where is the obstruction? And the majority of the obstruction is in the septum. With a deviated septum at 76%. Inferior turbinate enlargement was 72%, and then nasal valve collapse was 67%. Obviously, this does not add up to 100%, and that's because in most patients there are multiple sites that cause the obstruction. So the point of this slide is that it's it's a more complicated picture, not much more complicated, but it is more complicated than just the septum and the turbinate. And that's traditionally what our impression of the nose was in rhinology until probably the last 5 to 10 years, when there became new treatments for the nasal valve and we started to pay attention to this. Looking in the nose, so I still do get about once every other month, I'll get a referral from a primary care doc that said the patient has a nasal mass or a nasal polyp, and it's just the inferior turbinate. You know, I try not to blame them because they're not used to looking in the nose, but this right here is the inferior turbinate. Obviously, this is a cartoon. Up here is, it's the lateral, this is a lower lateral cartilage, and it's called the lateral crura. This is cartilage that comes down here, and this is the tight point on the nasal valve. And then this little bulge here is the septal swell body. But looking in with a regular nasal speculum, here's the columella. This is the left side. It's hard to see, even with a headlight and the speculum. I find it very challenging to see much information in the nose unless they have giant polyps or really deviated septum up front. So most of these patients I'll do a nasal endoscopy, and this is looking at the right side. This shows the inferior turbinate here. You can see the middle turbinate up here, and this is the septum. And you see this backward C shape to the septum, which is what gives this patient so much room on this side. This is cartilage down here called the maxillary crest. So if we have a lot of room on the right side, we know we're going to have very tight space on the left side. So this patient has a significant deviated nasal septum pushing into the inferior turbinate and really no measurable space. Now, this was done intraoperatively. That's why there's blood in the field. And just a quick shot of the patient. There's the middle turbinate, and here's the left side that shows the deviated septum. I can't even get my 2.9 millimeter endoscope past this obstruction. One of the other reasons I do the endoscopy is, and I'll show you something in a moment, is to look at the whole nose, because you just can't see the entire length of the nasal septum with a nasal speculum. Sometimes there's a big bone spur in the back. Sometimes there's masses in the nasopharynx, like large adenoids or even cysts. To determine if patients have nasal valve collapse, you ask them to breathe in. And this is me. Okay, here's my nose breathing in. You can see the sidewall collapses when I breathe in, and it's pretty common. And I encourage you all to look in a mirror or your phone camera and breathe in deeply through your nose and see if your sidewalls collapse. And if it does, then do a modified Cottle maneuver. And you can do that right now by breathing in. You see my nose collapses right here, but if I do this, it's so much better. And so if I could operate on myself, I would. And I just need to have trust in someone else to take care of my nose. Maybe I have trust issues, but if you do this modified Cottle maneuver on yourself and you find out that you breathe better by pulling your nostrils apart or sleeping with your hand stretching your cheek, that signifies that you have nasal valve collapse, like many people. This, just for historical purposes, is the normal Cottle maneuver, where you put an instrument inside the nose and you push out on the cartilage of the lateral wall, and that opens that space, just like what a breathe right strip does. Len, did you try this? Do you have nasal valve collapse?
Yeah, I tried it while you were talking, and I was okay.
All right.
Since you asked me a question, let me ask you a question. Most of my career, I told patients who came to me and said someone told them they had a deviated septum that the surgical procedure, at least in olden days, was overdone, and that everybody has a deviated septum. The question is, to what degree is it significant enough to cause nasal obstruction? And there was a day when too many unnecessary surgeries were done. But the data you showed might contradict that.
Well, I'll say the day that too many surgeries are done is still here. We still see people over operating. I'm gonna my kind of procedural step algorithm has changed, and it's changed because of this newer procedure. So I find myself doing fewer septoplasties than I did 10 years ago. And again, it's all because there's a newer way to treat nasal congestion that makes most people really happy. Now, maybe not perfect, but most people who get 80% better are happy, especially if they can avoid the operating room. But yeah, you're absolutely right. The septum, one of the things I tell patients, if it's not broken, don't fix it. And even though I may look in the nose and find a really deviated septum or a moderately deviated septum, if the patient's not complaining of it or not complaining of nasal congestion, then I tell them, hey, you have a deviated septum. If it ever bothers you, let me know. We can talk about fixing it. But you're right. Certainly don't need to fix every deviated septum because it is normal to have a deviated septum. It's just how twisted it is. That's what's unique to each person. This is a graphic example of the nasal valve, which we've talked about, the lateral cartilage here, the nasal septum with the swell body, and then the head of the inferior turbinate. And looking at acoustic rhinometry, the tightest part in the entire nose is the nasal valve, which is right down in this space. So it is a key part of nasal obstruction that we kind of have disregarded for most rhinologists because there wasn't an easy way to fix it. I'll talk about that momentarily. So this is another example of nasal endoscopy. There's a big cyst in the back of their nasopharynx. It was non-cancerous, it's just a thorn walled cyst, but that was when the patient got an upper respiratory infection. These cysts tend to enlarge quite a bit, and he always got really congested because of it. And it's pretty simple just to open this up and remove it. A sinus CT scan can be nice in these patients to make sure there's not a mass, especially if you don't have a nasal endoscope. And this shows the septal swell body that is this enlargement. And this is erectile tissue, just like the inferior turbinates are. And when people take PDE5 inhibitors, their nose gets congested because the inferior turbinates and the septal swell body dilates or engorges with blood. And there's a technique that kind of shrinks this that I'll chat about. This shows a deviated septum, and Len, kind of getting back to your point, well, how bad is bad that needs correction? And if you look at this axial CT scan, it doesn't really look that bad. So here's the tightest point, but if you draw a line on it, you can see that it really does obstruct the nasal airway quite a bit right at that point. Again, it's not horrible, but the other interesting thing when you have a deviated septum is usually there's compensatory hypertrophy of the inferior turbinate. You can see this left inferior turbinate is about twice the size of the right inferior turbinate. And there's some magical mechanoreceptors in the turbinate tissue that knows to enlarge that turbinate to fill the space vacated by the deviated septum. The reason that's important is if a surgeon's going to do a septoplasty, usually they need to reduce the size of the inferior turbinate at the same time. The idea is to get symmetry in the nose and not have asymmetry. Most of my patients who come in, I have them fill out a nose questionnaire, the nasal obstruction symptom evaluation. And really it's just 5 questions. It's easy for them to fill out. There's a severity scale. But the key for me in also figuring out do they have nasal valve collapse is this struggle to breathe during exercise. And that's related to when you're really trying to take deep breaths through your nose, if you're exercising, and also if you have sleep disordered breathing at night. And if they have a significant, 3 or 4 when they're having trouble breathing through their nose exercising, then that's another key indicator that they have nasal valve collapse. The frustrating thing, and I'm sure there's many, many, many more studies. This was just one of the more recent studies that I came across that looked at treatment with nasal steroids versus saline. And this was a randomized study looking at 6-week outcomes using the nose questionnaire that I just talked about. The minimal clinical important difference is a change of 24. That's out of 100. And they showed that with Nasacort, 2 sprays, both sides once a day, the nose score changed by nearly 6 points. With the saline control, it changed by nearly 4 points. So not overly enthusiastic. This did not differentiate allergic patients versus non-allergic patients. It was done down at Stanford. Sam Most was one of the UW facial plastics professors probably 15 years ago. But anyway, it just shows the limitations of nasal steroid sprays in the average person. So the traditional techniques, septoplasty and inferior turbinate resection, or reduction, I should say. And this surgery usually takes about an hour. It's not a rhinoplasty. It doesn't change the outside appearance of the nose. It just corrects the deviated septum on the inside and shrinks the size of the turbinates. But some people, their nose is just so messed up. Nothing personally against these two nice guys, but if they want to breathe better, they're going to need a rhinoplasty. And a rhinoplasty is not something that most rhinologists do. Rhinoplasty is it's a challenging surgery done by people who spend their whole careers working on the outside of the nose. And so people who need a rhinoplasty should be sent to a facial plastics specialist. And that's another subspecialist within otolaryngology. Here is a case of a 44-year-old female. She has no nasal valve collapse, no improvement with the Cottle maneuver. And you look in her nose, and this is an endoscopic picture, but it just shows nicely the inferior turbinate. That's quite enlarged because the septum is shifted off to the left side. This is looking at her right side. And here's looking at the left side. And you can see this is where the septum is pooching out. So it's kind of pretty simple for this one. She needs a septoplasty in order to breathe better through the left side. And at the same time, the right side inferior turbinate needs to be reduced because I'm going to straighten out this septum. And if I don't shrink the size of the inferior turbinate, she's now going to have horrible congestion on the right side. So that's why we do the turbinate reduction, not resection. Lots of different ways to skin the cat or to reduce the size of the inferior turbinates that I'm not going to spend any time on. There's coblation, RF energy, microdebrider blade, which cuts out tissue. This is another coblator, or bipolar cautery. But looking at all different techniques between preoperative and 26 weeks after the surgical procedure, if just a turbinate reduction was done, the nose score improved by 50, which is obviously better than the 6 that we got with a nasal steroid spray. Challenge, the thing that we always think about or should think about is this entity called empty nose syndrome. The symptoms are generally painful, dry, crusty nose that patients feel they are suffocating. We have no idea why this is caused in a very small minority of people who have a turbinate reduction. It's traditionally thought of as an over resection of the inferior turbinate. And classically, 20 years ago, surgeons would go in and just cut out the inferior turbinates for nasal congestion, and there was a higher rate of empty nose syndrome with turbinate resection. Up to 22% of empty nose syndrome patients had turbinate resection versus far less than 1% with turbinate reduction. So even though it's somewhat popular in online forums and many patients will ask me about it, it's rare. I've certainly seen it. I haven't seen it in my techniques or any of the other rhinologists at the University of Washington. I haven't seen it in their techniques for turbinate reduction because I think we're conservative. It's a lot harder to add tissue than it is to take it away. We did a study that was just published, I think last year, looking at this Westlaw database, and it records the outcomes for the lawsuits that make it to court. And in the US, between 1985 and 2018, there were only 39 reported cases of empty nose syndrome that actually made it into the final to trial. And these are not cases that settled. It's a lot harder to get that information because that case is usually blocked. But interestingly, surgeons prevailed in 87% of the cases. So it's, and there's different reasons of why these cases went to court. Surgery not indicated is one of the smaller ones, but it's just the claim of surgical negligence or lack of informed consent. And that's the thing that just drives me nuts is, I just don't get why some surgeons just do it without talking to the patients about it. It amazes me. And when you look at this map of where the cases came from, it makes you wonder what's going on in California, other than it's just a higher population. But you look at California and New York, it's like, yeah, it's population driven for sure. But even in California with the tort reform, you'd think the litigation would be less, but that's not the case.
Greg, a question. I see the name Weimuller up there.
Yeah.
But no,
So,
wasn't Ernie Weimuller the head of the ENT division? Is this pure coincidence that this attorney's got the same last name?
no, so Sims is Ernie Weimuller's son, or one of his two sons. And Sims and I met long ago at one of our department, Christmas parties or something like that, and stayed in contact. And then I was an expert witness for a case of his related to the Zycam litigation several years ago. And then when the med student, who was a med student at the time, and now he's a ER resident, when he came in and did his ENT rotation, he wanted to do research, and he was an attorney in his previous life, and then switched to medical school. And so we came up with this research project, and I reached out to Sim to help us with getting the data. So yeah. Really nice guy, though, just like Ernie is. All right. So I've been talking about the old stuff. What's new? And what's new is this thing. There's only one company. I blocked out their name, but there's only one company that does radiofrequency treatment for nasal obstruction, or one company that makes the device. It's a pretty slick device. It's a temperature controlled device that heats the tissue up to 60 degrees Celsius and not more. So it's not cautery. Cautery heats tissue up to about 400 degrees Celsius. So when this device touches the tissue, it just blanches the tissue. There's no smoke. There's no burning flesh. You don't see any scab or black eschar formation. It was shown during COVID times when a research study was done that it doesn't aerosolize tissue or virus particles, so it's safe to do. I wouldn't do it on a patient with active COVID, but it's safe to do in the COVID pandemic. And most of the time, this is done in the office. It heats up the tissue, and specifically heats up the submucosal tissue, not so much the surface. And the surface is where the mucus secreting glands are. And if we think that if you injure the surface too much, that can lead to empty nose syndrome. So that's one reason I like it. And it shrinks these vascular voids. Think about the turbinate tissue and the septal swell body as it's a sponge, basically. And in those pockets are what get engorged with blood during the nasal cycle, or in the gravity dependent time, if you're sleeping on one side. And so this will shrink those voids so that when you do have the natural nasal cycle, the turbinate doesn't enlarge so much. Also, for the side of the nose, it reshapes and stiffens the cartilage. And they did several animal studies with pig ears and showed that it stiffens up the cartilage without destroying the cartilage. And that's why it helps with the nasal valve. So you can get the nasal valve with it, the inferior turbinate, and then the septal swell body. And it's done with patients wide awake. I tell them to take Tylenol about an hour before they come in. And then I use this wonderful local anesthetic called tetracaine, and it's just squirted in the front of the nose as a gel. There's no injections early on, and you infuse that tetracaine gel and then walk away for 15 minutes and come back, and the patient's nose is numb, their upper teeth are numb. Then I do a couple really small injections into a few areas in the nose, and then I do the treatment. And the treatment lasts, it takes maybe 5 minutes per side. So start to finish, it's about a half-hour procedure, and 80% of that is spent gently, kindly numbing up the nose so that the patient doesn't feel anything. The average pain level now is a 1 out of 10. I've been doing this for 3 years. It's been out for 4 years. When I started doing this, I was doing injections all over the outside of the nose, intraoral blocks to numb up the nose. This was before I was using tetracaine, and it was not all that fun. I didn't look forward to doing the procedure, even though I knew it helped patients. It was just kind of a pain in the neck, and doing the injections on the outside of the nose wasn't fun for the patient or me. So once I started using the tetracaine, then it really got a lot better. I see the question, do I only do tetracaine or other canes in the office? So it's a great question. I I always ask patients if they have a hard time getting numbed up by their dentist, because the dentists are usually using lidocaine. And if they say yes, then I know that I may get more benefit by using tetracaine. The answer is I have lidocaine and tetracaine, so the ester and the amide. And doing a combination of two, again, tetracaine is what I do first, and then the lidocaine is what I do second with the injections. And it works really, really well. When I have done, since I switched to using this technique about a year ago, I haven't had any problems whatsoever. And it's just been a really nice procedure that kind of look forward to now, as opposed to before I didn't look forward to it.
Talking about the local anesthetics is obviously a separate issue that we deal with. Patients who come to us believing they had allergic reactions to the drugs, and I think most of us have never seen a positive case, that this really does not exist. I don't know what your experience is.
I kind of scratch my head about that too. I think probably anything's possible, but in the patients I've seen who come in and say they have a lidocaine allergy, I don't use it because there are alternatives. Yeah, but I agree. I question that. And hey, Paul McBride's asking if tetracaine is easily available since there's still a shortage of lidocaine. It's very easy. So the compounding pharmacy that most of you know I've used for a decade or so is Cascade Specialty Pharmacy, and they mix up the tetracaine. It's tetracaine pluronic gel. So it's this 20% pluronic gel with 10% tetracaine, which means it's liquid when it's cold. So we store it in the refrigerator. And then as soon as I put it in the warm nose, it turns to this somewhat firm gel. And that's why it sticks where I put it. And this is what I do now for all my in-office nasal procedures. If I'm doing eustachian tube balloon dilation or a sinus balloon dilation, which I don't do too often, or even touch up sinus surgery in the office, I'll use this tetracaine and it's great. You do have to prescribe it for each patient, so it's kind of a pain in the neck. Some people used to be able to get big tubs of it, but that's not the proper or legal way to do it. Oh, sorry about this. Anybody having a seizure? All right. Not quite sure what happened here. There we go. Okay, so this is just a short, very, very short picture of what it looks like to do the septal swell body. It's shaky because I don't use an endoscope when I do this. It's just a headlight, and it's really hard. Here's the RF wand on the head of the inferior turbinate. It's really hard to hold the endoscope outside the nose and get a picture. And that's the only reason I was doing it, was so I could show you what it looks like. And the blood is just from the local injection. It's not from the actual procedure itself. So again, it just heats up the tissue. You don't really see a lot happening before your eyes. I tell patients expect to have a stuffy nose for 1 to 2 weeks before it starts to get better. And that's the natural tendency for healing. But it works really well. And true story, first 5 patients I did this on, they came back and they said, oh my gosh, my life's so much better. Thank you so much. And I was really skeptical because I'm a skeptic by nature. I'm like, really? And they're like, yeah, that's so much better. Thank you. This is a month after the procedure. And then I did the procedure on my medical assistant's wife, and she is just a straight shooter. She'll tell you how it is. And she called about 3 weeks later, and she couldn't believe how much better this was. Her breathing was. So that's what convinced me. Now, the research shows that not everybody has a great response, and that's my practice too. The initial research study that came out a couple years ago looked again at the nose questionnaire, and they showed the pre-op nose questionnaire was 80. It was just 80 out of 100. That's pretty severe nasal obstruction. And then within 4 weeks, it dropped down to about 35, and it continued out to 26 weeks, where their nose score was down to 25. So quite a dramatic improvement. The 2-year results were published more recently, and that showed that it persisted. So 80 was the baseline, and then even out to 2 years, they had a substantial continued improvement in their nasal congestion. So it's just nice to know that what we're doing is not transient. I haven't had to repeat this procedure on anybody. Again, I've only been doing it for about 3 years now, but I would predict at some point in time I will, just because the turbinates do enlarge. There's a whole lot of quality of life metrics that have been done, and this is how much our patients improved. It's kind of a yes or no. And the key thing is better sleep throughout the night is improved, less fatigue during the day is 50-50, big decrease in the amount of nasal sprays and using breathe-right strips. All right, so that's, and that's, the procedure is called the VAIR. Again, right now it's the only company that makes the device. So hopefully the ENTs that you refer patients to are offering this to patients. Again, it keeps a lot of people out of the operating room. And I'll quote patients, I'll tell them 80% of patients get improvement with this procedure, which is what the research shows. And that means, 1 out of 5 don't. And sometimes it's because they have a really bad septum or really large turbinates, and patient selection is important in that situation. But it's worth talking about. And sometimes I'll tell patients, look, let's do this in-office procedure first. If it doesn't work for you, you do have a moderate deviated septum, we can always go to the operating room afterwards. Other times I'll look in the nose, and if the septum's really deviated, I'll just say, look, this procedure is not worth it. Your nose is so bad, we got to go to the operating room.
Greg, a question. There's a procedure which I think is not being done very much, but had a lot of study in the field of asthma, bronchial thermoplasty, essentially burning lung tissue. Is there any relationship to the kind of energy or temperature? Are you familiar with that at all? Or maybe some of my allergy colleagues can answer that question, if there's any similarity between these two approaches.
Well, this is radio frequency energy,
okay.
60 degrees Celsius. I have no idea what bronchial thermal obstruction is. Feel free, if anyone wants to chime in and talk about it, feel free to. It sounds scary. It sounds like a pneumothorax in the making, but maybe not. Yeah, biggest complication with this procedure is just that it doesn't work. It's highly unlikely to get any significant bleeding. Sometimes there's a little bit of crusting, and patients will use Aquaphor or Neosporin in their nose for a week or two. So I want to move on to another. This is, again, my goal is to tell you what's new so you can be aware of it if patients ask you. This device is called, there's only one on the market, so the name brand is Latera. This is a small plastic, absorbable plastic implant that goes right underneath the skin, and it overlies the cartilage. It spans the distance between the lower lateral cartilage down here on the nose and then up here on the nasal bone. And so when patients breathe in, you don't get that dynamic nasal valve collapse. It helps stent it open. It's done either under general anesthesia or local anesthesia, and the implant does dissolve in 12 to 18 months. A study came out very recently that showed the benefits last out to 4 years, and that's when the research study stopped. And the reason is it kind of makes a capsule around this implant as it's dissolving, and that's what stiffens up the tissue. So the ideal candidate is someone with a very positive caudal maneuver, someone who has pretty thick skin over the nose. Thin skin patients, there is a chance that you can see this implant because it does have a little bit of bulk, and they're not the best candidates for it. I do this procedure currently just under general anesthesia because I can get a much better placement, and I'll show you a short video about it, and you'll understand probably why I do it under a quick general anesthesia. The study about it came out on 137 patients. It was a randomized trial, so half the patients roughly got the implant, the other half just got the large needle going inside the nose and then being retracted without deploying the implant. And they measured success by having a 20% improvement in the nose score, that questionnaire. And that's generally considered what a minimal clinical important difference is. So success in the treatment side was 82%, in the sham side was 55%. And that's a huge sham response. Pretty impressive. So even driving the needle in creates an inflammatory response that stiffens up that area. where 55% of the patients are happy with their response. There are some potential side effects or adverse events. So 19 patients out of 137 had some adverse events. 4% of the implants had to be removed. Usually it's because of a foreign body sensation underneath the skin, or if you can see it, some swelling on the outside, and then pain. Infection is very uncommon with this procedure. I don't do this nearly as often as I do the Vivera procedure. But if I'm doing a septoplasty or a turbinate reduction, or if a patient just flat out has horrible nasal valve collapse, I'll do this. And it takes maybe 10 minutes in the operating room with minimal recovery. Here's a short, I got to show you like one kind of, it's not a gross picture, or video, but I always show you some videos. And so I wanted to show you what this looks like. And again, if you were awake and I was injecting your nose like this, it wouldn't be very fun. If I used tetracaine, it would not feel too bad. But this is just using a guide marker to kind of draw out where I want the implants to go. And this video is not very long. So there's the size of the implant, and this is the device that deploys it. It's kind of silly how expensive these devices are. But anyway, then you just tunnel this pretty large bore needle up over the nasal bone, and then you kind of push this button and deploy it, and then you wiggle it out eventually, slowly, and that's it. And that deployed the little implant inside the nostrils. So, and then it's done on the other side. All right. So that's Latera. And I'll show you now a couple cases of a decision-making. 19-year-old female, she's heading off to college in 4 weeks. She's got a lot of congestion, mainly with exercise and at night. No improvement with nasal steroids. Her septum's straight. She has really big inferior turbinates, probably some undiagnosed allergies. She has some mild nasal valve collapse, and I'll show you her picture. This is my daughter, and she gave me consent. So that's Claire, but when she breathes in, you can see her nasal valve collapses. Now, she has really thin skin and a tiny little nose and big inferior turbinates. So the plan for her, and the main reason that she went to the operating room, is she was getting left-sided nosebleeds. And so one of my partners did a little endocautery or control of the epistaxis, and then did a very gentle inferior turbinate reduction. And she had a very nice result. So again, less is better, and you can always do more. It's hard to take back what you do. So that's why I try to take things in a conservative fashion. In contrast, this is one of my former partners. He's a 44-year-old male, nasal congestion all the time. He's really bad with exercise. And he says, I just want to breathe. Do whatever you need to do. I just want to breathe. And he's got a pretty good, pretty moderate septal deviation. And here's his nasal valve collapse. And it's tremendous. Like when he breathes in, his entire sidewall, that left side is worse than the right, but his whole sidewall of the nose collapses in. So it's not a surprise that he's a mouth breather at night. And this guy is an avid athlete, and he has a challenging time when he's working hard. So the plan for him is going to be a septoplasty, turbinate reduction, and then he got Latera implants. Both patients are very happy. So wrapping things up from my point of view, the summary is nasal congestion impacts quality of life, and it's super, super common. We all see it. We didn't do much about it to treat it before, other than our standard things, because the treatment of nasal valve collapse before this RF came out was a rhinoplasty, big 3-hour surgery where you're taking cartilage from the ear and making the nose wider and reconstructing the nose. Hard to get insurance companies to cover that. It's easy for the Vivera procedure, and boy, it just, once you have a new hammer, you find the nail to hit, I guess. The proper assessment is key to identify the area of congestion, because that will determine what we do. And it's important to recognize that new things come around. They're not always great. There's a lot of things that come and go, but these 2 ways to improve nasal valve obstruction and collapse are quite beneficial to patients. So there's our word of the day as proof, and I'm happy to answer any questions you may have.
See something in the chat box?
Yeah, let's find it there.
How do you spell the Vivar?
It's Vivar, Vivar by, it's Vivar by Aaron Medical. And you can go to the Aaron Medical website and they have a find a provider, and you can type in, your practice zip code, and it'll tell you all the providers in the area, in your area, that do this procedure.
Is that the device with the radio frequency energy?
Yes, Vivar is the RF one.
So I have a classmate of mine who was, maybe he's retired now, the head of oral maxillofacial surgery at the MGH. And I remember there was always a concern, these various procedures are often amongst oral maxillofacial surgery, plastics, facial plastics, and rhinology in different centers, sort of who dealt with these patients. Do you have any thoughts how it is here in our region? Do these fields overlap, or?
I am not aware of anyone outside otolaryngology doing either of these procedures. I think part of it is these easier, less invasive techniques have allowed the general otolaryngologists, so you don't have to be a rhinologist, but it's allowed the general ENT to take care of this complex part of the nose, mainly the nasal valve. And versus historically, these patients would go to a facial plastic specialist or a plastic surgeon to get a rhinoplasty. And the facial plastic friends that I know still are doing just as many rhinoplasties as they have before. And I think that's because that's what they're used to doing. They're good at it. It's their bread and butter, and they haven't transitioned to these lesser invasive things. I don't know if that will happen or not, but again, part of it is just what's your bread and butter, and is this going to take away from rhinoplasty? And the answer is absolutely yes, in a good way. Now, if my career was doing rhinoplasty, I would be a little concerned.
Well, I mean, I always thought that was done mostly for cosmetic reasons, not for nasal obstruction. People wanted to change the exterior appearance.
Well, so rhinoplasty is either a cosmetic rhinoplasty or what's called a functional rhinoplasty. And the functional rhinoplasty, the whole point is to restore the function of the nose. And usually the facial plastic surgeon or general plastic surgeon will try to make the nose look a little bit better too. But it is one way of getting insurance payers to cover the procedure. And if someone has a really crooked nose and their septum is completely plastered to one side of the nose, they're going to need a rhinoplasty. And again, that's going to be called a functional rhinoplasty. It's a little bit harder to get insurance authorization, but it is possible. So it's not always just for cosmetic purposes.
One other question, you alluded to, but didn't say anything more about the nasal cycle, like when congestion changes from side to side. You want to say more about that?
Yeah, it's what most people come in with, a complaint of, my nose gets stuffy on one side and then it's stuffy on the other side, and it goes back and forth. And I have to educate them that that's normal. That is called the nasal cycle. And the nasal cycle just relates to the periodic change in blood flow to the nasal tissue, mainly the turbinates and septal swell body, from one side to the other. And it's different in everybody. It ranges usually between a 4 to 12 hour cycle. And I tell people, look, that's normal. It's okay. You're supposed to get stuffy on one side and then the other side. We don't know why that happens, but that's what happens. But I also tell people, look, if you're sleeping with your head down on the right side is going to get congested because that alters the blood flow to that side. If you do a handstand and your head's upside down, you're going to get stuffy on both sides because it's blood flow related. So I think it's important for me. I educate my patients about the nasal cycle before surgery because they're still going to feel that after surgery, and you don't want them to be irritated with normal physiology.
Anybody else out there with a question? We got Angela.
Do I ever get complaints from athletes on enhancing performance with nasal procedures? Complaints. Well, I get a lot of athletes in, both weekend warriors, college athletes, and professional athletes. And my hesitation, I don't want to oversell any procedure. I really, truly don't. But all the athletes that I've worked on, they come back and they say what a dramatic difference it made for their exercise tolerance. And it doesn't matter if they're NFL players or weekend warrior bicyclists. For most of these patients who you improve their nasal breathing, it helps dramatically. And I think part of that is just when they're exercising, they can breathe better, but probably a lot of it is also when they're sleeping, they have improved. If there's a couple studies that show if you improve the nasal anatomy, sleep apnea decreases by 1 degree of severity. So severe to moderate, moderate to mild, mild to potentially none. Even though we're not changing the tongue base or the palate, the nose is one of the 3 areas of sleep apnea. So I think that's probably making a big difference. It's fun to operate on athletes. It's really fun to do the Vivere procedure on athletes because they don't have a downtime. They can keep exercising. The very next day, they can go back to the gym and do their workout. They're just going to have a stuffy nose for a month or two. There's one of the Mariners came in. He's actually a Tacoma Rainier, came in at the beginning of the season and had severe nasal valve collapse. And I said, oh, let's just do this Vivere procedure. He's like, well, I think I'm going to get called up. He did get called up and he had a great season. And so now he's on my schedule to do the Vivere. So even though there's really no downtime, it's not something that I would do during athletes season. I'd do it in the off season.
Got another question? Is there anything?
Yeah, I'm sorry. I'm just reading it. You read faster than I do. I had to find. Is there anything we can offer patient with nasal valve collapse other than breathe right strips, or send them to me or my colleagues? Well, nasal steroid sprays. Really, every insurance company except for Medicare requires patients to try nasal steroids for 4 weeks before approving nearly any nasal procedure. So that's one thing. Even though we know it doesn't work all that great. Make sure they're not on a nasal decongestant. If they are, do the Afrin wean to get them off. That's going to help their breathing. And then, I mean, there's nothing really. If they have allergies, treat their allergies. I'm a huge fan of allergy shots, huge fan of Astapro. That stuff works great. But I can't think of anything other than the breathe right strips. But it's nice it's really diagnostic. If you send them home and say, try a breathe right strip and tell me if you are better during the day or if you're sleeping better at night. And usually it's the sleeping partner that will say if they're sleeping better at night with less snoring. And if they call you back and they say, yeah, the breathe right strip helps a lot. Again, that tells you it's the nasal valve, and it tells you, you can talk to them about options and they can decide if they want to do it or not.
Greg, are these new procedures available at the U? Are your colleagues there?
I don't think I could Google it right now or go to the ARN website. I don't think they're doing it right now. I know I wasn't doing it before I left just under 3 years ago. And part of that is it takes a little bit of staff time to get stuff set up and to get the tetracaine for each patient, things like that. And, in the past, we didn't quite have the staff to do many in-office procedures, which was frustrating. And I don't know what the status is right now. I'm not sure.
Well, as always, a very helpful, very educational presentation, very pragmatic stuff for us to know. Anybody else out there? Greg has left us some time for questions.
I always try to leave time for questions. Tuesdays are my operating room days, and then some Mondays. And so we start at 6:30 here. Yeah, which is crazy. I know. So I do have cases at 8 o'clock starting, but that's why a lot of times I can't be on this journal club. I really wish I could be on here more often than I am, because it's a great group that you have and always fantastic speakers. So thanks for allowing me to participate. Oh, one new message.
Okay.
You're welcome. Thanks, Angela.
All right, Greg, we'll let you get off to the OR. Thanks again.
Absolutely.
So
All right,
long, everybody.
have a great day.